Hi, and welcome back to my YouTube channel. By now you all know me, but if not, my name's Mario. I put out videos primarily on clinical research, and this is a video in a series of studying for the ACRP CCRA exam, or the Association of Clinical Research Professionals Certified Clinical Research Associate exam. And in this video, I am going to break down E11 of the guidelines. And if you're not familiar with E11, it's right here. It's the clinical investigation of medicinal products in the pediatric population. So the way I'm going to do this is I'm going to flip through this and cover things that I think are important. This video is not only relevant to those studying for the exam, it's relevant to anyone that works with the pediatric population in clinical research. So if you are interested about learning all about the regulations for pediatric populations in clinical research, stay tuned. All right, before I get started, as always, I need to take a moment to remind you to smash that like button and subscribe to my channel if you haven't done so already. The channel is almost at 2,000 subscribers, so slowly working my way there, so I appreciate your support. All right, so without further ado, I'm going to get started. So first I'm going to give you a little bit of my background, and then I'm going to flip through these pages quickly and cover things that I think are important for both the CCRA exam as well as for those individuals working in pediatric trials. So for those of you that don't know my background, I started off in pediatric oncology. I spent 3 years, 2 at Dana-Farber as a CRC there, and then 1 at Stanford as a lead CRC. Pediatric regulations is something that I am pretty familiar with, but it's been a while, so I use this as a refresher. So, all right, so I'm gonna get started and really talk about what these guidelines say. And you may see me flipping pages. I don't think everything in this guideline is testable. So I really want to focus on what's testable and what you need to know. So let's talk about the general principle. So pediatric patients should be given medicines that have been appropriately evaluated for their use in pediatric populations. Does that make sense? If you're giving pediatric populations medicines, you want to make sure that they've been tested in that population. So question might be, how do you decide what's appropriate to test in a pediatric population? And I think the best way to go about this is to look directly at the regulations and see what it says, which is the decision to proceed with a pediatric development program for a medicinal product, and the nature of that program involves consideration of many factors. And these include the prevalence of the condition to be treated in the pediatric population, the seriousness of the condition to be treated, the availability and suitability of the alternative treatments for the condition in the pediatric population, whether the medicinal product is novel or one of a class of compounds with known properties, whether there are unique pediatric indications for the medicinal product, the need for the development of pediatric-specific endpoints, the age ranges of pediatric patients likely to be treated with medicinal product, unique pediatric safety concerns with the medicinal product, and potential need for pediatric formulation development. And then it stresses here, the most important is the presence of a serious or life-threatening disease for which the medicinal product represents a potentially important advance in therapy. So that is something you want to note. So it's pointing out here that if there's something serious or life-threatening and it involves an advance in therapy, this is something that probably needs a relatively urgent and early initiation of pediatric studies. So the next talks a little bit about pediatric formulations. I don't think you need to know too much about pediatric formulations other than when you think of pediatric groups, they are pretty heterogeneous, as in there's all the way from newborns or preterm even, all the way to 16 to 18-year-old teenagers. So the way that you formulate and enhance compliance may vary depending on what age group you're dealing with. So, and also know that the toxicity can vary across age groups and between pediatric and adult populations. So the next whole section talks about timing of studies and when it's appropriate to start studies. This is really broken down into 3 sections. So the first one is medicinal products for diseases predominantly or exclusively affecting pediatric populations. And when you're dealing with disease exclusively in pediatric populations, you'd expect the majority of the data to come directly from pediatric populations. There's going to be one exception, and that usually safety and tolerability data comes from adults. Even in pediatric populations, initial safety and tolerability tends to come from adult, and later moves into the pediatric population. So the majority of your testing will be in pediatrics, but just note that initial safety and tolerability data may come from adults. So the next category is medicinal products intended to treat serious or life-threatening diseases occurring in both adults and pediatric patients for which there are currently no or limited therapeutic options. So just think, if there's no or limited, you want to expedite this. So again, you're going to want to design your trials to include pediatric population pretty early on, minus probably the safety and tolerability phase, which will probably still be done in adults, but then you want to get it into the pediatric population and test it there as soon as possible. So that's the second category. The final is medicinal products intended to treat other diseases and conditions. So if it is not something that is exclusively in pediatric subjects, or it is not something for serious or life-threatening where there's no proper therapies or no therapies that are effective, this is the third category. So intended to treat other diseases and conditions. So this is not an urgent thing. So you would expect that the pediatric population would be the pediatric subgroup would be enrolled much later into the trial after we have some pretty good data, since there's no urgency for this kind of a trial. So then it talks about the types of studies. So when a medicinal product is to be used in the pediatric population for the same indication as those studied in approved adults, extrapolation from adult efficacy data may be appropriate. So there are sometimes you can just extrapolate your safety tolerability data from adults into peds. And it says here, in some cases, pharmacokinetic studies in all age ranges of pediatric patients likely to receive the medicinal product together with safety studies may provide adequate information for the use by allowing selection of pediatric doses that will produce blood levels similar to those observed in adults. So this then breaks down when you can use what's a pharmacokinetic approach and extrapolation, and when it may be inappropriate. So it talks about just the one circumstance here: an approach based on pharmacokinetics is likely to be insufficient for medicinal products where blood levels are known or expected not to correspond with efficacy, or where there's concern that concentration response relationship may differ between the adult and the pediatric populations. And in those cases, it suggests a pharmacodynamic approach. I don't think this is really within the scope of the CRA job. We don't make decisions of how the trials go forward. What we would do in terms of PKs, PDs is make sure that the blood samples are collected correctly, that the time's noted, that they get shipped off appropriately. Those are more relevant to the CRA. But this is just some good background knowledge on when you can extrapolate from PK data from adults into pediatric subjects, and when it may be inappropriate, and also when you can consider pharmacodynamics. And on that note, the next section it talks about pharmacodynamics in more detail, just as pharmacokinetics rather, in more detail. So pharmacokinetic studies generally should be performed to support formulation development and determine pharmacokinetic parameters in different age groups to support dosing recommendations. So I won't dig too much more. Just know that dosing in pediatric populations can be done a number of different ways. So the most common for dosing is usually milligram per kilogram, but you could also be dealing with surface areas, and it might be really hard for some medications to figure out the height and weight, especially if you're dealing with newborns. So just know there are different ways to approach dosing recommendations. So you want to make sure whatever dosing recommendation you are suggesting is age appropriate. So the other thing with blood samples in general, and I can see this being tested, is that you want to make sure you are drawing the least amount of blood possible in this population. So the volume of blood withdrawn should be minimized in pediatric subjects. Blood volume should be justified in protocols. Institutional review boards, independent ethics committees review may define the maximum amount of blood that may be taken for investigational purposes. So that's all I see of relevance in this section. So Those are things you know. So blood samples, minimize the amount of blood for what you need, make sure it's reviewed, justified in the protocol and reviewed by the IRB or IEC. Okay, so the next section talks about efficacy. Obviously, we're very concerned with efficacy in trials. So where efficacy studies are going to be conducted, companies may want to develop, validate, and employ different endpoints for specific age and development subgroups. Many diseases in preterm and newborn infants are unique or have unique manifestations, precluding extrapolation of efficacy from older pediatric patients, and call for novel methods of outcome assessment. All right, so jumping, next section is going to be safety. So we want age-appropriate safety concerns. So we want to look at normal lab values and clinical measurements used in adverse event reporting. And because developing systems may respond differently from matured adult organs, some adverse events and drug interactions that occur in pediatric patients may not be identified in adult studies. So there might be differences in the kind of adverse events you see in pediatrics versus adults. Just know that normally the pediatric database is limited at the time of approval. So we are concerned about post-marketing information. So normally the pediatric database is limited, as I mentioned. So we want to look carefully at all the surveillance, post-marketing surveillance data that comes out so we can track potential adverse events, et cetera. So the post-marketing surveillance is really important in pediatric populations for this reason, because the amount of data may be more limited. The whole next section is about age classifications. And this is something that sort of logically makes sense, that there are going to be challenges based on different challenges based on different age groups. So it says for efficacy, different endpoints may be established for pediatric patients of different ages. And it breaks down one possible categorization. So one of the possible categorizations, and the ones they talk about, is preterm newborn infants, term newborn infants, 0 to 27 days, infants and toddlers, 28 days to 23 months, children, 2 to 11 years, adolescents, 12 to 16 years, and depending on region. So, and then they start breaking down each one of these and some of the concerns. So I'll just go over some of the main concerns. So preterm newborn infants, there's special challenges because of unique pathophysiology and responses to therapy in this population. So just know if you're dealing with preterm newborns that you're dealing with complex pathophysiology and such. So you want to be concerned about things like birth weight, for example. So preterm babies are not all obviously identical. Some may have low birth weight, some might be closer to normal. So that's some of the categorization. So the category of preterm newborn infants is not homogeneous in any way. So I could give you the examples of birth weights as one such thing that you may want to pay attention to. So study design for this population, you want to consider weight and age, gestational and postnatal stratifications, small blood volumes, a small number of patients at a given center, and differences in care among centers, difficulty in assessing outcomes. So those are all of concerns when dealing with studies designed to deal with preterm newborn infants. All right, so term newborn infants of 0 to 27 days. The thing here to consider is that the blood-brain barrier is not fully developed or fully mature in this. So you might see an excess of CNS or central nervous system toxicities. So the blood-brain barrier is still not fully mature, and medicinal products and endogenous substances may gain access to the CNS with resultant toxicity. Oral absorption of medicinal products may be less predictable than in older patients. Hepatic and renal clearance mechanisms are immature and rapidly changing. So that's what you need to consider when you're dealing with term newborn infants, so 0 to 27 days. Next is going to be infants and toddlers, dealing with 28 days to 23 months, and this is the period of rapid CNS maturation, immune system development, and total body growth. Oral absorption becomes more reliable. Hepatic and renal clearance and pathways continue to mature rapidly. So That's for that age group. Jumping into the next age group, which is children, 2 to 11. So most pathways of drug clearance, such as hepatic and renal, are mature, with clearance often exceeding adult values, and then specific strategy should be addressed in the protocol to ascertain any of the effects of the medicinal product on growth and development. So this is a crucial age between 2 and 11 for growth and development, and you want to pay special attention to that. So factors useful in measuring the effects of medicinal product on children include skeletal growth, weight gain, school attendance, and school performance. And then in this age group, also puberty can affect the apparent activity of enzymes that metabolize drugs, and dose requirements for some medicinal products on a milligram per kilogram basis may decrease dramatically. All right, so the last category is adolescents, 12 to 16 to 18, and this is a period of sexual maturation. Medicinal products may interfere with actions of sex hormones and impede development. In certain studies, pregnancy testing and review of sexual activity and contraception may be appropriate. This is also a period of growth and continued neurocognitive development. This is also the age where compliance may be an issue. So in clinical studies, compliance checks are important. Recreational use of unprescribed drugs, alcohol, and tobacco should be specifically considered. All right. So now let's talk about the ethical issues in pediatric studies. So the pediatric population represents a vulnerable subgroup. And I'm going to spend some time on this next sentence that I'm about to read directly. And this is section 2.6.1 under ethical issues in pediatric studies, because I think this is an important note, and this is something that I can see that being tested. So it says here, when protocols involving the pediatric population are reviewed, there should be IRB, IEC members or experts consulted by the IRB, IEC who are knowledgeable in pediatric ethical, clinical, and psychosocial issues. All right, so why did I pause and read that really slowly? Because I can see this coming up and being tested in a few ways, but the most logical way I see is a physician sees a 7-year-old patient, decides that there is no appropriate known therapy, but an investigational drug may benefit the patient. The investigational drug is not approved, and the physician wants to start the drug immediately. Can the physician just administer the drug to the 7-year-old based on their clinical judgment? And the answer unequivocally is no, absolutely not. If you're dealing with experimental drugs, you have this extra step here to make sure that you consult the IRB, IEC, and experts. So in my described scenario, one of the things that may occur is an emergency meeting of the IRB, IEC to discuss the potential use of this investigational product. But the physician cannot autonomously just administer an investigational drug. So this is something that's pretty specific in the guidelines, that this has to go through the IRB, IEC, and it has to be discussed with people knowledgeable in pediatric, ethical, clinical, and psychosocial issues. Recruitment, basically, don't force recruitment is the next section. So recruitment of study participants should occur in a manner free of inappropriate inducements, either to the parent or legal guardian or the study participant. So when studies are conducted in the pediatric population, an attempt should be made to include individuals representing the demographic of the region and the disease being studied. And then the next section, which is consent and assent, and this is section 2.6.3. This is probably where the heart of questions could come from dealing with pediatric populations, because there's a lot of considerations for consenting and assenting in pediatric populations. So I'm going to break down this section. I'm going to spend quite a bit of time because I see this is where a lot of the questions will likely come on for pediatrics in the CCRA exam. So as a rule, a pediatric subject is legally unable to provide informed consent. Therefore, pediatric studies participants are dependent on their parent or legal guardian to assume responsibility for their participation in clinical studies. All right, perfect. So it's very clear. It says that the parent or legal guardian is responsible, and pediatric study participants are unable to give consent. However, then it goes on to talk about, when appropriate, participants should assent to enroll in a study. So what happens if the participant, the pediatric participant, doesn't want to give their assent? That should be respected. Now there is an exception. So in most cases that should be accepted. But as you continue to read on, it does say that subjects, participants, and this is in general, should be aware to decline or participate or withdraw from the study at any time, that they have that option. So this is the last part of this 2.6.3 that I'm going to read slowly and just explain the exception. So although participants wish to withdraw from a study must be respected, there may be circumstances in therapeutic studies for serious or life-threatening diseases in which, in the opinion of the investigator and parents or legal guardian, the welfare of the pediatric patient would be jeopardized by his or her failing to participate in the study. In such a situation, continued parental or legal guardian consent should be sufficient to allow participation in the study. All right, so if we break down this section, we're basically saying that the parent or guardian is responsible for consenting. The subject, if it's age appropriate, is responsible to assent or can assent to the study, and it can also decide not to participate. However, in special circumstances, even if the subject doesn't assent, if there's a serious or life-threatening condition, ultimately the responsibility falls back to the subject's parents or legal guardians. So hopefully that's clear. This could be the heart of understanding consenting and assenting for questions that will come up on an exam. And it's also something that you should know in general if you work in pediatric trials. All right, so it also goes on to say studies in handicapped or institutionalized pediatric population should be limited to diseases or conditions found principally or exclusively in these populations. And then it talks about minimizing risk. Every effort should be made to anticipate and reduce known hazards. So the final section is minimizing distress. So repeated invasive procedures may be painful or frightening. Discomfort can be minimized if studies that are designed and conducted by the investigators experienced in the treatment of pediatric patients. And it basically breaks down some of the things to help minimize distress. So personnel that are knowledgeable and skilled, physical setting with furniture, play equipment, activities, conduct of studies in familiar environments such as hospital or clinic where participants normally receive their care, and then approaches to minimize discomfort such as topical anesthesia to place IV catheters, indwelling catheters rather than repeated venipunctures for blood sampling, collection of some protocol-specified blood samples when routine clinical labs are obtained. Again, IRB should be consulted for what's the appropriate amount of blood volume. So this is really a breakdown of everything you need to know for the CCRA exam for the E11 and pediatric populations. So I think hopefully this is helpful. Like I said, if you are about to take the exam, I would read through the guidelines, watch this video, and really see what I highlighted and the kind of questions that I personally think with, I guess, 15 years of CRA experience and 3 years of coordinator experience are relevant. So, all right, so I'm going to end this video here. This is a long video. These videos are going to be long because I would really want to try and highlight everything you need to know, and also some of the questions in this section. So I will specifically mention these types of questions that I could see being asked. In the next video, I will cover E9 and the statistical principles that you need to know. So if that's of interest to you, stay tuned for the next video. As always, if you've made it this far and you haven't done so, please take a moment and smash that like button, and I will see you in the next video. Thank you for watching.